Hello and welcome. Thank you for joining the PolicyLab webinar series. This is Meredith Matone, Deputy Director of PolicyLab at the Children's Hospital of Philadelphia. PolicyLab is a center of emphasis within the Children's Hospital of Philadelphia Research Institute, one of the largest pediatric research institutes in the country. Our mission here is to achieve optimal child health and well-being by informing program and policy changes with interdisciplinary research. Our webinar series is just one of the tools we use to translate our research into policy solutions at the local, state, and federal levels. We are excited to launch our webinar series with this inaugural webinar focused on vaccinations and the concept of vaccine hesitancy. This is a topic that is grounded in our nation's public health history and continues to remain relevant in pediatric clinical practice. Leading our PolicyLab webinar series today are Drs. Kristen Finster and Dr. Paul Offit. Dr. Feemster is a faculty member at PolicyLab and an assistant professor of pediatrics in the Division of Infectious Diseases at the Children's Hospital of Philadelphia and the Perelman School of Medicine at the University of Pennsylvania. Dr. Feemster is also medical director of the Philadelphia Department of Public Health Immunization Program. Dr. Offit is the director of the Vaccine Education Center and a professor of pediatrics in the Division of Infectious Diseases at the Children's Hospital of Philadelphia. He is also the Maurice R. Hilleman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. We hope you enjoy this research focus and timely discussion today, which coincides with the release of our new PolicyLab Evidence to Action Brief that you'll be hearing more about from Dr. Feemster. If you have questions while viewing the program, we've included contact information at the conclusion of the webinar, and we encourage you to reach out. We'll be summarizing questions and our responses in a follow-up blog post to the webinar on the PolicyLab blog. Thank you, and we hope you find the discussion today informative.
As Meredith mentioned, we are here today to talk about addressing vaccine hesitancy and to summarize some of the findings and recommendations from our newly released PolicyLab Evidence to Action Brief entitled Addressing Vaccine Hesitancy to Protect Children and Communities Against Preventable Diseases. My name is Kristen Finster, and I am a pediatric infectious diseases physician and a health services researcher here at the Children's Hospital of Philadelphia. I am one of the faculty in PolicyLab, and I also serve as the Director of Research for the Vaccine Education Center and the Medical Director of the Philadelphia Department of Health Immunization Program. As a member of PolicyLab, I am part of a group of more than 25 faculty whose mission is to achieve optimal child health and well-being by informing program and policy changes through interdisciplinary research. In brief, our goal really is to build evidence in order to inform effective policy, particularly related to public health topics associated with child health.
Hi, my name is Paul Offit. I'm a professor of pediatrics in the Division of Infectious Diseases at Children's Hospital of Philadelphia, as well as the director of the Vaccine Education Center at CHOP. At CHOP, the Vaccine Education Center's task is to dispel misconceptions and misinformation surrounding vaccines by providing information directly to the patient, the parent, and to the media.
So our goal today is to really review these three topics. So first, we want to spend some time talking about the implications of low immunization rates and increasing vaccine preventable diseases that we've seen related to vaccine hesitancy. And then to identify some of the key factors that contribute to vaccine hesitancy. And lastly, to explore approaches to address hesitancy and increase vaccine acceptance through both provider and public policy solutions. So much of what we'll talk about today is a summary of some of the highlights from our newly released Evidence to Action brief. Evidence to Action briefs are published by PolicyLab and highlight research from our faculty. And we seek to present evidence that and then propose evidence-based local and national policy solutions related, as I said earlier, to child health in order to improve outcomes for children. We are an independent research center within the Children's Hospital of Philadelphia, and we hope that the information that we provide can be useful for a broad audience. So to begin with, we will first talk about the epidemiology of vaccine acceptance or vaccine hesitancy and rise in vaccine preventable diseases.
So this slide shows how successful we've been. If you look at the incidence of diseases like diphtheria and hepatitis B and paralytic polio at the time when they were causing a significant amount of suffering and hospitalization and death in the United States. Most recent reports show that we've had 98 to 100% decreases in almost all of these infections. This shows you the power of vaccines. But to some extent, vaccines have been a victim of their own success. The fact of the matter is that while my parents, for example, who were children in the 20s and 30s, saw diphtheria as a common killer of teenagers, or saw polio as a common crippler of children, and I, as a child of the 50s and 60s, had measles, had mumps, had German measles, had chickenpox. My children, who were in their early 20s, not only don't see these diseases today, they didn't grow up with these diseases, so they're much less compelled then about the importance of vaccines. So in fact, this slide shows sort of the epidemiology of vaccine refusal. The majority of physicians report more than one vaccine refusal per month. More than 90% of physicians report requests to spread out vaccines. 1 out of 5 physicians report that at least 10% of parents make requests for an alternative schedule. Now, there is actually no alternative schedule. There's the schedule recommended by the CDC, Centers for Disease Control and Prevention, and the American Academy of Pediatrics. The other schedule, the so-called alternative schedule that was put forward by Dr. Robert Sears, is not an alternative. Let's call it what it is. It's a delayed vaccine schedule that puts children at unnecessary risk. And 13% of children are under-vaccinated due to parental choice. Now, this slide shows, I guess, in more depth what kinds of decisions parents are making. So you can see that there is not only a fairly high incidence of children who, for example, haven't received their first vaccine till say age 5 or 6 months, when they're supposed to get it at the hepatitis B vaccine at birth and a series of vaccines at 2 months of age. But this shows you the delays, and not only, and worse than that, the sort of the increasing percentage of people who are then choosing to delay, withhold, separate, or space out a variety of vaccines. This shows you a sort of at a state level that it's interesting that there are some states that are at or about 95% of what is expected to be the MMR vaccination coverage for a study that was done by the CDC between 2015 and 2016. But other states are more woeful. There are a series of 3 states you see there, Indiana and Kansas and Colorado, that have less than 90% immunization rate, which is interesting because if you look at Mexico overall, Mexico has an immunization rate of greater than 95%. All right, next slide. This slide shows a study that was done by Allison Kemp in Colorado, looking at sort of pediatricians' attitudes about these delayed schedules. So she asked questions. So, for example, the first question, parents choosing to quote unquote spread out vaccines put their children at risk for contracting a vaccine preventable disease. Interestingly, 53% of pediatricians strongly agreed with this statement, with which one should obviously strongly agree. 34% agreed but not strongly, and 13% basically disagreed with that statement. The second question she asked was, is it more painful to children to bring them back repeatedly for shots rather than give them multiple shots at the same time? Again, about half agreed strongly, 35% agreed not so strongly, and 60% disagreed with that statement, which is to say that they were fine with bringing children back for time and time again for multiple shots, when in fact you could bunch shots so that they would have to get vaccines less frequently. And interestingly, studies have shown that you're no more stressed out getting 2 or more shots at once than if you get a single shot at once. And the way researchers did that was to look at cortisol secretion as a measure of stress. And so, which is to say, you're maximally stressed out at one shot. So if you're just bringing children back frequently for shots, or worse, you're delaying vaccines, putting them at risk of vaccine preventable disease, but also making it more likely they're going to remember that they've gotten these shots. So you're doing far more harm than good. The last question that Dr. Kemp asked was, if I agree to work with parents in spreading out vaccines, it allows for a greater degree of trust between us, with which 24% strongly agreed, 58% agreed, but 18% disagreed. Again, it's really about protecting the child. It's about making sure that the child doesn't walk out into a world that is progressively more dangerous, with more measles, more mumps, more whooping cough. That's I think, the job of the pediatrician, to put the child in the safest position possible. It's not really to, I think, encourage in any way a parent to allow a child to catch and transmit a potentially fatal infection. Next. So this shows the measles incidence before and after the MMR vaccine was introduced. The vaccine was actually the measles vaccine alone was introduced in 63, the mumps vaccine in 67, the rubella vaccine in 69. The MMR vaccine was combined into a combination vaccine in 1971. But you can see that there was a dramatic reduction of measles following that vaccine. Unfortunately, in the last 2 years, in 2014, there were actually about 680 cases of measles that occurred in Ohio, primarily among an Amish community. In 2015, and this is the outbreak that got all the attention, there was an outbreak that started in Disneyland and spread up into 25 other states, as well as 2 Canadian provinces, that affected about 189 children. So this looks actually at that Disneyland outbreak. There were 189 cases reported in 25 states in 2015. 5 outbreaks represented 80% of those reported cases. It's interesting that the 2014 epidemic, which was 3 times bigger than the 2015 epidemic, got very little play in the media. And I think that was because it was seen to affect an Amish population in Ohio, and people thought, that's okay, I'm not going to go visit the Amish in Ohio, my kids are fine. Whereas in 2015, because it occurred in Disneyland, which I think was seen as a shared space, as a commons, that people then really did care. But we should care about all children, including Amish children in Ohio. And I think we should have had the same level of outrage in 2014 that we had in 2015.
So what are some of these dynamics that we just reviewed reflect? I think, as Paul mentioned earlier, over time, with the success of immunizations, we really have seen a reduction in concerns about disease risk, because the risk of many of these diseases just don't seem very imminent. Certainly, the measles outbreak in 2015 made measles seem like a possibility. But in general, there has been a lower perceived risk of vaccine preventable diseases. And when that happens, that provides space or room for there to be more concerns about the need for and safety of vaccines. In addition to that, I think there's also been really an underappreciation of disease severity. And so when you think about what a disease like measles can do, for example, for some parents, especially if you haven't experienced it, you may think about it as, it'll cause fever, it'll cause rash, that's it, you recover. But measles is something that can result in death in 1,000 children, at a high rate of hospitalization. And so many of these diseases can be quite severe, and it can be very difficult to predict for whom those outcomes, will take place. And then lastly, and I think this is probably one of the most important drivers of some of these changes that we've seen, is a rise in easy access to misinformation. And so, many vaccine safety concerns are fueled by misinformation. Yes, certainly, vaccines are associated with can be associated with some adverse events. No medical intervention is 100% risk-free, but these adverse events are things like fever or some swelling at the insertion site. But moderate to severe adverse events related to vaccination are very, very rare, and there are many things that are discussed and raised by parents as concerns that are often fueled by misinformation or stories that are shared on a wide range of media sources. And some of these sources seem quite credible. It can be very difficult for parents to tease out what is real and what is not. And so I think that this pie chart kind of reflects how some of these forces really interact. And so, you have this rapid dissemination of information, and it can be difficult to really evaluate the verity of some of this information. I think there's also been kind of a rise in distrust of information, particularly from institutions that have once been kind of held as credible, including public health institutions and even the media news outlets, and certainly over the past few months, we think about discussions about alternative facts and fake news. There really has been a lot of questions about who you can trust and who you cannot, and in that setting, it can be very difficult to communicate evidence and talk about science. Because you have a rapid dissemination of information, I think there also can be a distortion of risk. And thinking about the measles outbreaks is a good example. In 2014, you had an outbreak associated with a higher number of cases. But the concern about risk was probably amplified when we talked about measles being associated with Disneyland, because it seemed like a higher likelihood of potential exposure, and there was just more coverage about it. And so when you can disseminate information more rapidly, it's much easier to kind of lose context and really understand what the true risk can be. There's also been really changes in decision making when it comes to medical decision making in particular. That we focus a lot more on shared decision making, and that can be very, very important for patient care and reviewing options for different interventions. But that also does provide a platform for parents to bring their concerns to the table and play a more active role in decision making about immunizations, and so may question a provider's recommendation more frequently. And then lastly, the rise of naturalism. And so I think if we think about the number of organic goods and non-genetically modified goods in this grocery store, for example, we focus a lot on making sure that things are natural, and we don't want to put things in our bodies that are not natural. So, is natural infection better? And so, yes, natural infection can certainly give you an immune response that may offer you protection down the road, but it comes at the cost of disease. And so, sometimes, I love organic goods as well, but naturalism may not result in the best outcome. Prevention is important as well. And so I think there are just so many factors at play that have influenced the rise of vaccine hesitancy. So, we've been talking about vaccine hesitancy. So what is it? What is the definition? What does this really mean? And so there have been a lot of people thinking about this. And so, for example, the World Health Organization, their strategic advisory group of experts convened a working group on vaccine hesitancy, and define it as follows here, really is illustrated by this diagram. And so it's, the interplay between three key factors. So the first is related to complacency, and I think that is really what we've just been talking about. This is a lack of or underappreciation of the risk for or severity of vaccine preventable disease. So you really just don't prioritize, getting vaccinated, and so you just have some complacency. It's not seen as important compared to other, health interventions, for example. Convenience is another factor. So related to, the ease of getting a vaccine or getting to clinic for vaccination. If it seems that there are too many barriers and you're not, highly value the need for vaccination, you may be less likely to pursue immunization services. And then last and most importantly is really related to confidence and trust. So how much do parents trust the safety of vaccines, the effectiveness of vaccines, and the need for vaccines, and how much do they trust the medical system or the public health system providing immunization services? So these three main factors are also influenced by a wide range of other influences. And this really just demonstrates the complexity of this issue. So, it's not just complacency, confidence, and convenience, but all of these things are certainly influenced by our exposure to media, stories we may have heard in the news, our own history or the history within our own community of a vaccine preventable disease. It may be influenced by our health beliefs in general, or what our neighbors are doing, what our friends are doing. And then they could also be related to vaccine-specific issues. So is this an expensive vaccine? Do I have to pay out of pocket? Can I get to clinic? a wide range of factors that influence one's decision to get vaccinated or to decline vaccination. So because of that, vaccine acceptance is not kind of a one-size-fits-all definition. There really is a spectrum. And I think it's important to understand the spectrum of vaccine acceptance because that really allows for tailoring of immunization programs or your own response to a hesitant parent or patient. And so these are just two conceptual frameworks for the spectrum of vaccine acceptance that have been proposed by different investigators. And really, as you can see here, it really ranges from, on the far right side, immunization advocates or unquestioning acceptors. So these are maybe people who are highly accepting of vaccines and highly motivated to get themselves or their children vaccinated. And then at the far left, you have those who are, refuse all vaccines or become worried about vaccines, and so may have strongly held beliefs related to vaccination and choose not to accept any vaccines. And then in the middle, where probably the majority of people you have individuals with who may have some concerns about vaccines, but generally will accept recommendations, may accept some but not others. And in the middle groups, I think that we really have an opportunity to potentially influence decision making by being able to address some of these concerns or other factors related to hesitancy. So when we think about the issues that we're really dealing with and then consider how we may address them, I think there are three key things. So one is the diminished prioritization of vaccination, perhaps related to kind of complacency and underappreciation of risk. Two is a lack of confidence in vaccine safety and efficacy. And three is also related to state policies around immunizations. So why do we, why are we focusing our attention on really thinking about hesitancy and potential solutions? And that really is because a decision to delay a vaccination increases the amount of time a child is at risk of contracting a vaccine preventable disease. And if our goal is to do what we can to ensure good health outcomes for children, optimizing implementation of immunization recommendations and timely immunization is important, not only for that individual child, but also for the community in which they live. So when we think about the lack of confidence in safety and efficacy, it's important to think about where that's coming from. So as I mentioned earlier, this is often based on misinformation. And so whether it's anecdote that's shared widely, or it could be kind of misinterpretation of a fact about a vaccine. A lot of this is based upon misinformation that could be addressed with clear communication about both the vaccine and vaccine preventable disease. But this is often perpetuated, in the media or through the internet. And if you look at some recent studies, it's shown that the majority of individuals do refer to the internet to inform some of their health-related decisions, and particularly decisions related to immunizations, and also kind of highly rate some of the stories and that they may see on different sources, including sources like YouTube, that are known for, kind of perpetuating information based upon anecdote. So I think beliefs that are supported by exposure to different kinds of information on the media, in the media and online, can be really difficult because they are so pervasive and can sometimes be quite powerful. And so then when we're talking about inadequate state policies, I think this is another very important consideration. So, in the U.S., probably the cornerstone of our, immunization policy is related to school entry requirements. All 50 states require a certain set of vaccines prior to entry for kindergarten, middle school, and sometimes daycare, and that has really supported the overall high immunization rates that we've seen. But while we do have school immunization requirements, we also have exemption policies. So ways in which parents may request an exemption for that requirement. And the way in which those are implemented can have a significant impact on immunization rates. So for example, all 50 states do offer a medical exemption. So any child who has a contraindication to receiving a vaccine, a parent can request an exemption. But most states also offer a religious exemption, so 47 of the 50 states. So if you communicate a religious belief against immunization, you may be able to claim an exemption. And then many states also provide a philosophical exemption. So 17 states provide a philosophical exemption. And really that's based upon any belief that one has, whether it's any objection to immunization can be put forth as for a philosophical exemption. And so this diagram here, this figure here, illustrates the distribution of the different kinds of exemptions that states have. And there has been a few studies that have looked at the ease of obtaining some of these exemptions and their relationship with exemption rates. So what is our current policy climate? I think it's important to really think about and talk about a policy, immunization policy, because vaccine refusal is an individual choice that does affect others. And so when you decide not to get a vaccine for yourself or your child, not only is your child unprotected, but they are then potentially susceptible to a vaccine preventable disease that if they do contract it, they could potentially spread to others. So, herd immunity really is a public good. It's something we all share together. So for that reason, policy becomes, immunization is a part of public policy. And so if we think about ways to address hesitancy, we need to think about ways in which policy can influence vaccine decision making. And so I've already talked a little bit about mandatory immunization programs. So that is one key and important policy approach here in the US. And the US is one of few countries that do require immunizations, actually. Offering incentives or penalties related to immunization is another policy approach. And then considering other things like optimizing access. And so, insurance coverage, other ways, policies that may make it easier for, to get vaccinated in other places besides provider offices. Anything that increases access to vaccines can be an important policy approach. And then thinking about how policy may influence, what we believe and how we feel about immunizations as well. So, vaccines, they have been in the news, certainly. And there's been ongoing and recent public attention, related to immunizations. And, largely with our, current administration, there's been the discussion about a potential, vaccine panel to review these alleged association between vaccines and autism in particular, to potentially be led by an individual with, by Robert F. Kennedy, who is a known vaccine skeptic in many ways and has strong beliefs about vaccines. And even though this is a question that has already been asked and answered in the literature, even though we already have a very robust vaccine safety infrastructure to review these questions. But this really has, whether or not this panel is established, it still has brought, vaccine safety into the limelight and kind of given it a voice in politics. And also importantly, I think this idea of making sure that vaccine science is something that is supported. And so news about vaccines is everywhere, as we can see here. So let's talk about some of our policy recommendations. And so, what can we do? We can certainly improve healthcare providers' ability to make strong vaccine recommendations. We can think about our strengthening and enforcing vaccine mandates for school entry, and then we can improve public vaccine education awareness and access.
So for the rest of the webinar, Chris and I are going to be talking about what we can do. I'll start with the first one, which is to improve healthcare providers' ability to make strong vaccine recommendations. So one of the most important predictors of vaccine acceptance is exactly that. It's the physician who comes in and makes a strong recommendation. So for example, with the human papillomavirus or HPV vaccine, sometimes what will happen is a clinician will walk into the room and say, today to the adolescent, to the 11 to 13-year-old, today you're scheduled to receive the Tdap vaccine and the meningococcal vaccine. We also have the HPV vaccine if you want it. There have clearly been studies showing that the stronger the provider recommendation, the clearer the recommendation, then the more likely it is that the patient will receive that vaccine, as it says in the second bullet point, that we can significantly improve vaccine recommendations by making a stronger recommendation. Healthcare educators should place a stronger emphasis on training about vaccine safety, efficacy, and communication at all levels of career training, because frankly, I think a lot of people leave medical school and even residency without really being able to answer some of the more sophisticated questions that parents have. Obstetricians should counsel mothers before giving birth about the importance of following the vaccine schedule. It's the obstetrician, arguably, who is in the best position, actually, to talk to the future parent, because they're the ones who often see them first, and they're not always great about being strong about vaccines. Even the two vaccines that are given during pregnancy, which are the pertussis and influenza vaccines, those immunization rates are only about 50% to prevent diseases not only that can affect the child, but also the mother. The provider should aim to reduce or eliminate the number of patients on alternative vaccination schedules. Again, I would like to make the point that there is no such thing as an alternative vaccination schedule. There's the delayed vaccine schedule, which does nothing but put the child at increased risk. I give Dr. Roberts here's credit for using the word alternative. It's a great word, right? Alternative energy, alternative music. There is no alternative vaccine schedule, just the one recommended by the CDC and American Academy of Pediatrics. Fourth, states should help strengthen immunization information systems by requiring all providers to report doses for children, adolescents, and adults. And finally, states should require third-party payers to provide adequate reimbursement to providers for the full cost of vaccination services. Providers can easily provide evidence-based information in a way that's easy to understand and addresses parents' concerns. This, in fairness, people call it the deficit model, which is to say that that if people don't know things, that they're going to be convinced by providing evidence, which I think is true to a point. But I do think that evidence alone isn't enough. It's not simply what you say, but how you say it. And so I think that information needs to be framed in a way that's emotional and compelling and passionate and compassionate if you're going to convince people. Because, frankly, we're convinced far more by fear than reason. I mean, ever since we crawled out of the ocean onto land, if you believe in this whole evolution thing, then what you'll find is that our amygdala and hippocampus, our centers of emotion, were far more developed than our cerebrum, which is, you look at those pictures of skulls as we move further along. The skulls get bigger as our cerebrum gets bigger. The point being, the cerebrum was late to the game. So appeals to emotion actually do work.
All right. And so what can we also do to strengthen and enforce vaccine mandates for school entry? Because as Paul mentioned, communication is important, and provider recommendation is a key influence on decision making related to vaccines, but may not always successfully change beliefs. And so, are there policy approaches as well to help influence immunization behavior? And so, immunization mandates. And so, mandatory requirements for school entry, really they're effective when they're meaningful and when they're enforceable. And so, as I'd alluded to earlier, there is variability across states in terms of how they are implemented, because laws and regulations governing these immunization policies are established at the state level. So the key principle to consider here that really provides the kind of justification for school entry requirements, and this is something that kind of has been upheld by constitutional law, is the principle that parents who choose not to vaccinate their children for non-medical reasons impose additional risk of contracting a preventable disease, not only on their child but also on the entire community. So, what can states do, or what can, we do as advocates within our own states? So the first is related to the availability of non-medical immunization or vaccine exemptions. And so one potential policy option is to pass legislation to eliminate non-medical vaccine exemptions. And also to enforce existing mandates for entry to both public and private school. And so there have been some notable examples of this. And so California, for example, recently passed legislation to eliminate both religious and philosophical exemptions for entry to any school within the state. And Rhode Island, Vermont. Vermont also recently passed legislation to eliminate the religious exemption. And there are several other states, particularly in wake of the 2015 measles, Disneyland associated measles outbreak, that have introduced and considered legislation to reduce the availability of non-medical exemptions, or to make it more difficult to get exemptions. So what do I mean by enforcing existing mandates for entry to both public and private school, or to use regulatory measures to make the exemption process more rigorous? So not only are there different types of exemptions, but there are different ways in which you can go about getting them. And so in some states, it's as easy as a parent just writing a statement saying, I don't believe in vaccines, and submitting that to school. But in other states, it requires some documentation from their healthcare provider, notarization perhaps from a notarization, or documentation that they've received education about vaccines or vaccine preventable diseases. And there have been studies to show that the steps that you have, the more that you have to do in order to achieve that exemption, maybe is associated with lower exemption rates. And so even in states that do offer philosophical or religious exemptions, changing what needs to be done to achieve those may be a way to increase immunization rates as well. And so one other potential approach could be through the imposition of a fee, really, or you could kind of call that kind of a penalty, really, for proposing a non-medical vaccine exemption. And so that may be through the imposition of for filing a non-medical exemption. And such fees could potentially be used to support immunization programs, or, for example, outbreak investigations if there's an outbreak of a vaccine preventable disease, because those do pose quite a financial burden on public health programs. So the third policy approach is really related to public vaccine education, awareness, and access. And what we can do from a policy perspective to communicate accurate and compelling information that stress the benefits of vaccination, and stress that the benefits of vaccination outweigh any perceived risk or inconvenience. And so this is really thinking about what kinds of public service announcements, for example, what kind of imagery will be most compelling. And this is an example here. What did Hannah bring back from vacation? T-shirts, snow globe, measles, but using imagery in a way in which that can really communicate strong messages and kind of positive messages about the benefits of vaccination, because that can influence what one thinks and believes. It's kind of similar to social marketing. So states and local health departments can invest in public awareness campaigns. And I think that anti-vaccine groups have done that very effectively in terms of really leveraging a wide range of media outlets to promote messages. And I think states and local health departments can also work with these different media outlets to promote kind of accurate and compelling messages as well, to promote the benefits of vaccination. When we think about other important policy options related to access in particular, or also that can potentially influence decision-making about vaccines, what can we do from a payer perspective? And so there could be federal legislation that may allow payers to offer lower cost health insurance premiums based upon immunization status. This is certainly done related to smoking and other health-related behaviors. So is this something that could be applied to immunization status? And then, what can states do to help make vaccines more accessible to children so that they can access immunization services? So, for example, school-based health clinics or the ability for children to be vaccinated in pharmacies. And while this not be intended to kind of take the place of a medical home with a pediatrician, the goal really would be just to improve access to immunization services. And then related to that, of course, to increase the pharmacist's ability to recommend and administer vaccines to patients of all ages. This is an approach that's been particularly important for adult immunizations, but a pharmacy may be a location for children and adolescents as well. So that really provides a summary of our key policy recommendations that we describe in more detail in our evidence to action brief. So in conclusion, vaccines really are one of the greatest public health accomplishments in history, and because of that, I think, as we said at the very, very beginning, have in some ways become a victim of their own success. Also kind of fueled by misinformation, easy access to misinformation, and unfortunately misguided fear, as well as complacency that can lead parents really just to question and want to understand more about vaccines. And sometimes these questions can lead to a decision to delay or refuse vaccinations for their children. So as stakeholders, there is a lot that we can do to encourage vaccination, and we encourage you to review the recommendations that we provide. So please email us at PolicyLab with any questions that you have, and we will answer them in a follow-up blog post on the PolicyLab website.
There is a Vaccine Education Center webinar on March 22nd, which actually is going to be talking about whether or not the human papillomavirus or HPV vaccine is associated with chronic disease, which is a question that comes up often. I'll give you the short version of that webinar, no, but there's a much longer version that you can hear on March 22nd.
And these are some additional resources as well. Thank you very much. And we look forward to seeing some questions from you.
Thank you.